Hello everyone, my name is Bruno Campos. I'm going to make a video divided in two parts. The first part is about the coronavirus and the COVID-19. I'm going to discuss the pathophysiology of the disease. And the second part of the video will be about some preliminary studies of some of the antiviral medication that medical doctors are using and researchers are exploiting. I'm also going to discuss the vitamin D evidence in acute respiratory diseases. And I'm going to go through a topic that caused some controversial opinions a few weeks ago in using in some of the use of hypertension medication and diabetes medication, anti-inflammatory medication that could eventually aggravate um, the symptoms and the signs of the COVID-19. This was something that the World Health Organization um sent out some feedback and some opinions, some advices. Um, it also changed its opinion a few times, and also the researchers and doctors are not sure. So because this was a bit controversial, I'm going to go into that as well. It's important to say that this is a merely a formative and for educational purposes. The video. I'm not a doctor. I'm not a nurse. I'm not a researcher. I'm an osteopath, full practicing. I also teach in the university, and for that matter, it's just a educational video, as I mentioned. So, well, like I assume almost everyone, I'm in quarantine at home, self-isolation, social distancing, and these mitigation actions are the best way we can prevent and lower the infectious rate and lower the eventually the death rate with this mitigation measures. So I'm at home and I don't have the usual support of a classroom, so it's a bit rudimentary this video, but I think good enough to understand. So let's start this. SARS CoV-2. So this virus is called the SARS uh, coronavirus 2. So it's the novel coronavirus 2, uh, meaning severe acute respiratory syndrome for caused by the novel coronavirus 2. We had the first SARS CoV in 2002 2003 with the first coronavirus, and now we are seeing it again. And it causes a disease called coronavirus disease, discovered in 2019 in China for the first time in November. It's also important to realize that there's a lot of different types of coronaviruses, and you probably got infected by some of the coronaviruses that got you maybe some flu or some pharyngitis or laryngitis or so there's different types of coronavirus. This novel coronavirus 2 and the first one are um, they have some different characteristics and a bit different from the common coronavirus. The major difference is that it just jumped from animal to human. So um, in the 2002 2003, they think it was either from bats to snakes to cats and then jumped to human, and this one they believe from bats probably to humans or pangolin to humans. uh, and what that does is usually the virus like influenza virus or the common coronavirus, they prefer a more cold temperature. So they kind of replicate better in a cold temperature, like the mouth or the nose or the throat, the upper respiratory tract. These guys, because they jump from directly from animal to human, they replicate better in a warmer temperature, like 37, and that's human's body temperature all over the body except the mouth and the throat. So that's why they tend to go deeper in the respiratory tract and connect to a special receptor. So this virus has this capsidium that protects the virus outside the host, and the virus can live for up to hours to days outside the host. It's a strong capsidium full of proteins, and these proteins, these spikes, can connect inside a cell through an enzyme that we're going to go into that. So it has a key to a lock, a special key to a special lock, and once inside the body, in a warmer temperature, it can go inside the cell. It's a very simple virus. It's a very simple guy. Um, Let me say simple, quote unquote. So it has some proteins around it, and has one filament of RNA, and it's 1/10 of a micrometer. So a micrometer is the millesime part of a millimeter, and it's 1/10 of that. So it's quite minuscule. Um, so inside the body, it travels through the respiratory tract, and so it travels through the respiratory tract, and eventually it will reach the lungs for the majority of cases. So this is a sagittal cut from a lung. You have the bronchi, the primary bronchi, the secondary bronchi, the tertiary bronchi, and then it divides in bronchioles, and the bronchioles or bronchioles. They also have some divisions, and then they end up in this green sacs of air. They're called the alveoli, or alveolar sacs. And these sacs are very important because this is where the gas exchange, the oxygen and dioxide carbon are exchanged. Uh, and inside the lung, inside the lung parenchyma, it will reach through the pulmonary ileum, pulmonary artery, and pulmonary vein. That will also reach the end part of the lungs, and will also be arteries and veins in the form of capillaries will be surrounding this alveoli to allow the gas exchange. So if we zoom in onto the alveoli, uh, so this is a one alveoli, and as I was saying, it's surrounded by the capillaries. Capillaries are the meeting point between a vein and an artery, and we actually call this capillaries the venule and the meta-arteriole. And this is very important because the carbon dioxide is traveling through the vein and the venule, and then eventually reach this place, and it will go inside the alveoli, and we breathe out the carbon dioxide. So we'll travel through there, and we breathe out the carbon dioxide. And the opposite thing happens with oxygen. We breathe in oxygen, and oxygen will reach the alveoli space, and then it'll eventually go in the meta-arteriole, and then the arteriole, and then the artery, and will follow the arterial blood to supply oxygen to organs. Uh, and this area here, if we cut this area, a small piece, and we zoom in again, it's fascinating because the alveoli, it's fused to these capillaries. So the different cells, we call this epithelial cells. If we cut a part of the alveoli, it will be something like this. If we kind of open it up, and the epithelial cell of the alveoli will be fused with the endothelial cell of the metaarterial and the capillaries, actually, both vein and artery, both venule and the metaarterial. If we do the same cuts, if we open up, we'll have this endothelial space. And this is very important, this fusion, because it allows for a gas exchange. So it's much better as a gas exchanger for the tissues to be fully fused, connected, glued. Otherwise, gases would have to travel. And so like this, they can actually go inside and outside perfectly. So we breathe out carbon dioxide. Carbon dioxide is one of the metabolic acids that it's the only one we can actually breathe out. The other ones have to be expelled in different ways. And you have to understand that, with cell functions and cell production of substances and enzymes producing and metabolizing substances, etc., we produce a lot of acids. And in conjunction, they're called metabolic acids. And carbon dioxide is one of them. And it's the only one we can actually breathe out. And then the oxygen will reach this space because every cell needs oxygen to function, and will reach the alveoli and will eventually go into the metaarterial. So this space here we call the blood-air barrier, or alveoli capillary barrier. In this space, in the alveoli, between the alveoli and the artery, in the artery, we have some specific cells, and they're called the pneumocytes, type 1 and type 2, and the macrophages. The macrophages are white blood cells. They have an immune capacity, immune response. So they're responsible for, cleaning the some toxicity that might happen here from this gas exchange, some debris, cleaning, attacking some pathogen agents, some virus or bacteria, or any infection that can happen in this. So we have this macrophages. They're immune cells. Pneumocytes type 1 they're very close to this blood-air barrier, and they help in this gas exchange. They facilitate this gas exchange. Pneumocytes type 2, they produce something called pulmonary surfactant. And pulmonary surfactant is a lipoprotein substance that it's the objective, the goal of this lipoprotein substance called surfactant is decrease the superficial tension. And what is the superficial tension? It's the tension that exists at the surface of these tissues, this epithelial tissues and endothelial tissues, and in the interstitial space, meaning the space between different cells, that is caused mainly by water. You know that we have water inside and outside the cells. So because we're talking about a space where gases need to pass through, in and out, and from the alveoli to the blood, and from the venous blood to the alveoli, if this gas is very tiny molecules, if they have to resist water, because water is all over the place, if they have to resist water, that it's hard for the gases to exchange. And these gases are not being they're not being moved by some special protein that uses some energy and can actually expel or suck in, or no, they just have to, they just go in or out through diffusion, through movement, let's say. Uh, so this pulmonary surfactant is very important because what it does is decreases the cohesion the of the molecules of the water molecules. So the water molecules are less cohesive, so they have more space between the molecules of water, and the surfactant does that. So what happens is if there's more space between the molecules of water, so the gases can actually pass through with more ease. And that's the importance of this pulmonary surfactant produced by the pneumocytes type 2, as we're going to see more ahead. So what we have here, we have a pneumocyte type 2, and so this is the cell. This is a pneumocyte type 2. This blue area, and in the cell membrane of the pneumocyte 2, we have a special receptor, and this receptor, this enzyme, it's called angiotensin converting enzyme type 2. Angiotensin, as you might know, is a hormone that is implicated in the blood pressure and in the rise of the blood pressure through some mechanisms. And we're going to go into that more with more detail in the second part of the video. So this angiotensin converting enzyme type 2, it exists in a lot of different tissues, in the lungs, as we see, in the alveoli, in the arteries, in the intestines, in the kidneys, in the heart, in the atriums and in the atriums of the heart, um, some in small number in the brain. Um, but they exist in large quantities in the lungs, in this area here that I'm showing. So this enzyme is a door, and this the virus, this coronavirus, has this spike-shaped protein, and different types of proteins. One of them, the S spike shape, connects with this enzyme. As it connects with the enzyme, it has the ability to go inside the cell. And it goes inside the cell, pulls the enzyme with it, meaning destroys it, and it starts to take over of the organelles of the machinery of the cell. And once it uses the machinery of the cell, it can produce new proteins. Remember, the virus is composed by proteins. It can produce new proteins. It takes over of the nuclei of the cell, and it means it can replicate is RNA. So once, because it's a fairly simple organism, let's say, um, it can reproduce itself. It can replicate itself, and once it does replicate itself, it leaves the cell and goes on to attack a new cell. And in the process of doing that, obviously, he destroys also this pneumocyte type 2 and goes off and attacks a new cell, destroys the new cell, and so forth. How does the body react to this? So again, we have a alveoli here, and if we zoom in on the alveoli, remember I told you you have pneumocytes type 2, and then you also have some immune cells. They're called the macrophages. They have this three nuclei shape inside. They have three nuclei, and they're shaped like this. Um, and these immune cells, they produce what we call cytokines. And cytokines are basically inflammatory or pro-inflammatory substances. And these are very important because it's the first attack, it's the first immune response to attack any foreign agent, any pathogen. So as the cell is being destroyed, these macrophages start to produce the cytokines. The cytokines are lots of them, different names, different types. We can call them all cytosines or pro-inflammatory substances like turmeric, turmeric necrotic factor, interleukines. I mean, there's different types of interleukines. We'll go again in more detail in another video. So it starts producing this immune cells, this pro-inflammatory cells. Why? Because it's trying to fight the virus and it's trying to minimize the damage that is being done in the cell. Uh, and once it produces these pro-inflammatory substances, these substances are produced in large numbers and they start to leak out from the alveoli. And where do they go? They go into this space, and this space is called the interstitial space. So it's a space between the alveoli, it's a space between the vein, the capillaries, the metaarteriole, the vanuli. So it starts to fill up the space also with this number of substances. These pro-inflammatory substances, these cytosines, they also act in the arteries, in the capillaries, in the metaarterioles, because they have the ability to cause a contraction in the metaarterioles and in the arteries in general of the cells. So what they do is these pro-inflammatory substances, these cytosines, one of the response part of the inflammatory process. Um, one of the responses, one of the things that happens is inside the the capillaries, inside the arteries, we have these closed, very close together cells, endothelial cells. They're very, very, very tight. And in the presence of an inflammation and an immune response, what needs to happen? What needs to happen is more substances, more immune cells need to arrive to the area to fight whatever infection or whatever trauma, whatever is happening in that location where the inflammation is happening. So it's kind of the macrophages and mainly these macrophages in the beginning um, um, start to call out, to call out their buddies, and they have a bunch of systemic responses. So some other types of white blood cells can reach the location, like neutrophils or monocytes or stuff like this. In order for this other immune cells and other and more inflammatory substances reach the area, they travel in where through the highway, and the highway is the blood, and and um, and the road it's the artery. So once in the area, the artery needs to open up more. So the cells need to be spread more apart, these endothelial cells. And these inflammatory substances have this capacity. They stimulate some special proteins inside the artery or the metaarterial, and they form this gap between the cells. So these special proteins inside the artery, I'm not going to go into that in detail, but they contract and they open the space between the cells. So what we can see is actually that is these endothelial cells open up, they have formed gaps, and they allow for diffusion, for leaking out substances of the immune system, like more macrophages, more neutrophils, more monocytes, etc., more inflammatory, pro-inflammatory substances. And this is part of the inflammation, part of the inflammatory response. And this is why, in any inflammation, one of the first things, if it's a serious, like a trauma or some substantial inflammation, one of the things you see, and this can happen, it can happen even if you twist your ankle or your foot, for instance. One of the things you see, the first things, is edema. And oedema is it's more substances outside its space. So if there's more substances outside its space, they're leaking out. This is basically called oedema, more fluid coming out to the interstitial space. And this is caused by vasodilation. What happens is, because this we're talking about this very aggressive and that lasts for a long time, this alveoli the damage being damaged. um, what can happen is so many substances are being produced and so many substances are being leaked out from the arteries that this exudate, this inflammatory exudate, this inflammation can actually starts to compress the alveoli and starts to compress this space. So this is symbolized here with these arrows. It starts to compress. There's more fluid around and it starts to compress the alveoli. And this is very, very important because, as you might remember, in this space, the pneumocytes type 2 are supposed to produce this pulmonary surfactant that allows for gas exchange, for a better gas exchange. So what happens to the alveoli once it starts being more, squeezed? Well, if it's being squeezed around it, so it means that the tension around the alveoli and in the alveoli is increasing tension. If the alveoli was this big and now it's being compressed, and it's smaller, its radius decreases as well. So if this guy goes up and if this one goes down, it means it increases the pressure. So the pressure increases in the alveoli. What does that do? Well, it kind of, for one side, the pneumocytes are being destroyed and the pneumocytes are producing less pulmonary surfactant. The idea of the pulmonary surfactant was to decrease superficial tension, but as we see here, the tension is rising. So what does that do? Less capacity for gas exchange, less capacity for um, releasing CO2, carbon dioxide, and breathing in to the artery the oxygen. So less oxygen goes into the blood and less carbon dioxide goes out. It leads to alveoli oedema. It leads to alveoli collapse. And this might cause something called hypoxia, less oxygen in this area, as we saw, and eventually hypoxemia, which is less oxygen in the arterial blood that goes into the organs, etc. These could lead to an accumulation of CO2, carbon dioxide, and eventually other metabolic acids, as I explained earlier. It could lead to something called acidosis. That can be respiratory acidosis, as we're seeing here, or it can be metabolic acidosis if it affects other organs, as we're going to see later. So, interleukin, turmeric, necrotic factor, leukocytes, neutrophils, as I said, monocytes, they all trying to fight the virus. And in the process, they might succeed in some part. They might be 100% successful, not so successful. It really depends. And but in the process, they produce these proteases. They're trying to regenerate the space itself, the alveoli, etc., etc. And in the process of destroying the virus, they also might destroy the alveoli. And so this causes scar tissue, fibrotic tissue. It causes, you remember, there's a lot of fluid in the area as well. So this leads to alveolar consolidation, meaning the alveoli loses it's either just it's completely damaged permanently, or it loses its capacity of viscoelasticity, this insufflation capacity. So its function it's quite limited, either from fibrotic tissue or some fluid in that space. And this is part of the local inflammatory response that unfortunately, or quote unquote again, quote unquote again, it's just a part of the immune response. As we're going to see in the part two video, this is this hyperactive and prolonged immune response is also responsible for some of the signs and symptoms the patients are feeling, like pneumonia, for instance. Um, and this is also what is seen, for instance, in other patients that has nothing to do with the coronavirus, for instance, smokers or asthmatic patients or pulmonary emphysema. Uh, this is basically what happens. And this is why these people, these patients with chronic pulmonary obstructive disease, smokers, for instance, are in a higher risk group with this coronavirus. But I'll go more into that again in the second video. And we have also a systemic, meaning a more global inflammatory response. Some of these substances here, some of the interleukin, are going to stimulate a thermoregulator in thermoregulation centers in the hypothalamus that are going to produce fever. And this is important to stimulate the immune system. They're going to stimulate the liver to produce something called reactive C protein, which is important in the immune response as well. And they're going to stimulate the spleen and the bone marrow to produce more white blood cells. So the initial symptoms, and I must say 80 to 90% of patients have only mild to light symptoms. I think the latest data in Portugal was that 91% of patients have mild to light symptoms. And partly the mitigation process is actually to protect the risk groups. People or patients with underlying conditions, underlying diseases, are more at risk. So the initial symptoms, and maybe the only ones you might experience, is something called dyspnea, which is the lack of breath, the lack of air. You're feeling you need more air, you can't breathe enough air. The shortness of breath, so your breathing is very shallow. You kind of breathe in a more shallow, superficial kind of way. Um, at the same time, you're experiencing lack of air. Why this lack of air? Because less oxygen is going in, because your alveoli and your lungs might be, with fluid. So the gas exchange is not happening, or is not happening with the same rate. So you experience it. You experience this. And tachypnea, which is the um, increase of the breathing rate. So because you're having less oxygen, you're trying to breathe more rapidly to increase that oxygen rate, that oxygen intake. Dry cough, and eventually production cough with productive cough. So as the alveoli start to being attacked, you're trying to cough out the inflammation and the virus. Fever, it's a very common one, and eventually something called tachycardia or hypertension, meaning the increase of blood pressure and the increase of heart rate. And this happened also for a reason that I'm going to explore in the next video. So what are the late symptoms and more the complications of this COVID-19? Again, someone who has the coronavirus might not experience the symptoms at all. It's just a complication of it. So what can happen? What can happen is the hypertension, meaning the decrease of blood pressure, because of the decreased blood volume. Uh, Less blood goes into the organs, less perfusion of the organs, and can lead to systemic failure. So if this process continues, this inflammation, this immune response, if it's prolonged and if it's way high and activates a lot of immune cells and a lot of this leukocytes and monocytes and this, it can lead to a vasodilation, if you remember. And this vasodilation, if it's too prolonged in time, and if it's being recruited by many cells, immune cells, it can lead to overall vasodilation in the systemic circulation. So that what happens is in the systemic circulation of this vasodilation, the blood starts to leak out from the arteries and eventually might not reach enough blood to the organs. So because there's less blood volume inside the arteries, it will lead to a decrease in blood volume. And decrease in blood volume it's going to cause hypotension. Vasodilation also causes hypotension. There's less blood reaching to the organs, and that can lead to systemic failure. For instance, in the kidneys, the irrigation of the kidneys with the blood, it's very important, and in changings of pressure inside the kidney, that also helps the kidney to expel through the urine, for instance, uric acid and creatinine. If the kidney is not expelling so much uric acid or creatinine because there's less perfusion, more accumulation of those acids inside the kidney, acids and creatinine, that can lead to kidney failure, and that could lead to these substances leaking out to the interstitial space, leaking out to the bloodstream again, and that's very toxic. The same thing can happen to the liver, accumulation of bile acid, of interleukins, C-reactive proteins, angiotensinogen, glucagons, or glucagons. I mean, so many different proteins produced by the liver that, if they're not used, they can be accumulated in the liver. That can also cause liver failure and eventually toxicity. Less oxygen in the lungs, less oxygen in the arterial blood, and that can lead to an increase of metabolic acids. That can lead to, like I said before, a acidosis, respiratory acidosis, and metabolic acidosis. So, and this can lead to eventually sepsis or septicemia, which is the toxicity and the infection and the toxicity aspects of all these acids and all these proteins and all these metabolic acids are in large number inside the body. It can lead to a very low pH and a bunch of complications, eventually ending up in failure of the organs. Also, implications in the GI tract and genitourinary tract. So, in the second part of the video, as I said, I'm gonna explore a bit what's the purpose of this recommendation of an article that came out in the Lancet a few weeks ago about the use of non-steroidal anti-inflammatory drugs, because it could increase the the death rate, the complication rate, and just create more complications with this COVID-19. Again, researchers are not sure; they're not in agreement. Um, Basically, there's a big question mark around it, but it's a topic that I found interesting. The evidence about vitamin D in acute respiratory diseases, what they're discovering now in the pulmonary studies with some of antiviral drugs, anti-malaria drugs, used also in rheumatic diseases, and with good results. The use of ventilation and steroids, but mainly focus on these topics here and the anti-inflammatory. That will be the second part of the video. Okay, I hope you liked it. It's probably a bit long, but if you're an academic, maybe you're used to this long talks, or if you're just not a health professional but a citizen, and I hope you found useful this information, and see you on the second part of the video. Stay safe, stay isolated. Social distancing is the best mitigation measure, and hopefully this will all be over soon, and hopefully we'll also come out of this with new insights about the way we live. Thank you.